Travis. I'm a third-year plastic surgery resident, and I'll be talking to y'all today about vascular insufficiency and chronic ischemia of the hand. I'm going to start with reviewing some of the basic anatomy. Having a good understanding of the vascular anatomy of the hand is critical for proper treatment. The primary blood supply to the hand is through the radial and ulnar arteries, which arise from the brachial artery in the proximal forearm. The ulnar artery gives rise to the common interosseous artery, which becomes the anterior and posterior interosseous arteries. In the distal forearm, the radial artery can anastomose with these arteries, which can also be a possible source of secondary collateral blood flow to the hand in cases of chronic ischemia. In the hand, the radial and ulnar arteries form the deep and superficial palmar arches. The superficial palmar arch is formed from the ulnar artery as it crosses the wrist. There is significant variability in the superficial palmar arch. In one study, shows a complete palmar arch in about 84% of specimens, with a complete deep palmar arch in 97%. The deep palmar arch is formed from the radial artery as it passes dorsally to the APL and EPB tendons, and then returns volarly in the palm after giving rise to the princeps pollicis artery to the thumb. And the primary venous drainage of the fingers and hands is through the dorsal veins, which drain to the basilic and cephalic veins in the forearm. So ischemia in the hand is caused by one of three factors, either vasospasm, occlusion, or a combination of the two. Ischemia is the result of a loss of both nutritional flow and thermoregulatory control. Vasospasm results from increased sympathetic tone, which narrows the lumen of the vessels and slows blood flow, which can eventually lead to thrombosis. So patients with vascular disorders typically present into one of three categories. The first is traumatic. Acute traumatic ischemia, such as arterial lacerations, is beyond the scope of most of this talk. You can have delayed traumatic presentations, such as post-traumatic aneurysms. The second category we'll look at is ischemic causes, which can be acute or chronic as well. Acute causes would be something like an arterial embolism, while chronic causes include disorders such as Raynaud's, inflammatory arteritis, atherosclerosis, and thoracic outlet syndrome. And then last category is tumors, which can be either congenital or acquired. Examples of congenital tumors include arteriovenous malformations, and acquired tumors could be a glomus tumor or malignancy. So of course, your evaluation of these patients starts with a thorough history. You want to ask about any cold intolerance, numbness, cramping, color changes to the hands or fingers, any wounds on the hands, either current or in the past, any tobacco use. You want to ask about any acute or repetitive trauma, and also discuss any medical comorbidities such as diabetes or coronary artery disease. You want to perform a thorough hand examination, of course, assessing range of motion, musculature, but paying particular attention to the vascular exam of the hand, looking at skin color, temperature, turgor, capillary refill, and peripheral pulses, either with palpation or Doppler. You want to palpate for any masses or thrills, and you should perform an Allen's test in these patients as well. You can also assess for any splinter hemorrhages, fingernail changes, or digital ulcers that may be a sign of more chronic etiology. So as far as imaging for these patients, ultrasound can be useful because it provides real-time blood flow evaluation of larger vessels. Angiography is the gold standard for vascular imaging. Either a CTA or MRA is acceptable. Angiography also permits concomitant interventional procedures, such as thrombolytic delivery or thrombolysis. Cold stress testing, in which you submerge the hand in cold water for several minutes, then use a laser Doppler to measure rewarming, can be useful. And then you also perform your test for a digital brachial index, which is similar to the ABI in the lower extremity. And if this number is less than 0.7, that may signify an occlusive issue. The image here shows an arteriogram of a patient with recent ischemic symptoms in the thumb and index finger who had suffered thrombosis of the radial artery in the snuff box with subsequent embolization to the thumb and index fingers. So we'll touch briefly on acute ischemia. So again, traumatic ischemia is, we're not going to talk too much about today. Iatrogenic causes of acute ischemia include arterial catheterization. Usually isolated radial artery puncture, like for a blood gas, is unlikely to cause ischemia of the hand. However, indwelling catheters like an A-line have been known to cause permanent ischemic changes in up to 0.09% of patients. Another thing you'll come across is vasopressor use, which can result in digital ischemia in up to 2% of patients on high-dose vasopressors. Typically, you'll manage these with local wound care to prevent progression to wet gangrene with eventual amputation once they've demarcated and recovered from their illness. You can also have ischemia from an AV fistula, which happens due to a steel phenomenon. And this is best treated with distal revascularization with interval ligation. And another cause, thromboembolism, we'll talk about on the next slide. And then isolated venous thrombosis in the upper extremity is fairly rare. But patients with near total thrombotic occlusion of the deep and superficial veins can develop ischemic thrombosis, also known as phlegmasia cerulidolens. The images here show a patient on the top who was on high-dose vasopressors who developed tissue necrosis from hand ischemia. And on the bottom is an ICU patient with signs of hand ischemia, including cyanotic fingertips and poor turgor that resolve with warming the patient and removal of the radial artery catheter. So thromboembolism, about 15% of all emboli go to the upper extremity. The heart is the most common source. Typically, these patients will have AFib or have had a recent MI. Other sources include thoracic outlet syndrome, atherosclerotic plaques, subclavian or axillary artery aneurysms, Takayasu disease, mechanical graft problems, penetrating trauma, and then catheter-related causes as well. Patients with macroemboli from the heart will usually have immediate symptoms of acute arterial obstruction. You'll think about the 5 Ps for these: so pain, pallor, pulselessness, paresthesias, poikilothermia. And then patients who get microemboli that shower to the distal arteries in the hand will have symptoms similar to Raynaud's, which we'll talk about later. And these are best diagnosed with arteriography. So treatment, emboli, especially larger emboli, need to be treated aggressively. You can perform a proximal arteriotomy and an embolectomy using a Fogarty catheter. You want to make sure you're using a catheter that's small enough to pass into the superficial and deep arches of the hand. You can also perform percutaneous intra-arterial thrombolysis and then surgical revascularization as well. For patients with chronic pain from distal small vessel occlusion, you can perform a surgical dorsal sympathectomy. And then all patients who had emboli from the heart should be started on immediate heparin therapy and will usually need to be on some sort of long-term anticoagulation as well. So moving on to chronic ischemia. So we're going to start with the vasospastic disorders. Start with Raynaud's phenomenon. This is first described by Maurice Raynaud in 1862. It's characterized by episodic vasospasm with reversible ischemia of the peripheral arterioles in the hand, which is classically triggered by either cold exposure or emotional stress. The prevalence is somewhere from 1 to 7%. Risk factors include female gender, family history, smoking, and migraines. The mechanism is poorly understood. It's thought to be mediated by sympathetic alpha adrenergic innervation and exacerbated by endothelial cell dysfunction, including increased endothelin 1 activity and decreased nitric oxide activity. You can have primary Raynaud's or Raynaud disease, or secondary Raynaud's, Raynaud syndrome. Primary, there's no underlying disorder. This is vasospasm alone. This typically has a benign course. Secondary Raynaud's is related to an underlying systemic condition, and this can have significant morbidity, including digital ulceration and gangrene. It's associated with a number of rheumatologic conditions. The most common association is with progressive systemic sclerosis or scleroderma, but it's also associated with rheumatoid arthritis, lupus, Sjogren's syndrome, mixed connective tissue disease. We're tested on CREST syndrome, which is an acronym for calcinosis, Raynaud's, esophageal dysmotility, sclerodactyly, and telangiectasias. Other associated conditions include hematologic disorders, mechanical injury from vibrations, and other vasospastic disorders such as migraines and Prinzmetal angina. It's also associated with certain medications such as beta blockers and serotonin agonists. If you're suspicious for a rheumatologic condition, you want to work these patients up for that. Check a CRP, an ESR, ANA, rheumatoid factor, and then if indicated, these patients need further workup, refer them to a rheumatologist. The diagnosis, these patients will have cold sensitivity and biphasic color changes in addition to 3 of the following criteria, which are triggers other than cold, bilateral symptoms, numbness or paresthesias, well-demarcated areas of involvement, photographic evidence, and triphasic color changes, which is well-demarcated pallor or white, which progresses to cyanosis, which is blue, and then lastly, reactive hyperemia, which is red upon reperfusion. So management, typically you'll start with behavioral modifications, including cold avoidance, smoking cessation, and avoidance of certain medications. Medical treatment is typically reserved for refractory primary or secondary Raynaud's. Medications to treat this include calcium channel blockers. The most commonly used drug is nifedipine and alloprost, which is a vasodilator. Botulinum toxin is another option. The mechanism is poorly understood, but it's thought to be due to inhibition of the sympathetic mediated vasoconstriction and inhibition of substance P mediated pain signaling. Studies have shown that it helps with pain relief, increases blood flow to the fingers, and improves function in patients with scleroderma. And this is injected onto the volar aspect underneath the dermis and repeated every 4 to 6 months. Surgical treatment is for patients who fail medical management, who have persistent digital pain or ulcerations. You can perform a periarterial sympathectomy, in which you strip the periarterial adventitia and disrupt the sympathetic tone to the vessels. The image here shows an angiogram in a patient with scleroderma who had decreased flow in both their common and proper digital arteries, who underwent a sympathectomy. Complications for primary Raynaud's are rare. Occasionally, you can see ulceration or tissue loss, but typically the prognosis is very good. Secondary, the complications and prognosis are related to the underlying disease. Raynaud's can be a marker for underlying disease that may lead to significant morbidity and mortality. So it's good to be aware of this. All right, moving on to Hypothenar hammer syndrome. So this is traumatic thrombosis of the ulnar artery in the palm. It's most common in males, smokers, and people who have repetitive trauma to the hand. So where the ulnar artery emerges from Guillen's canal, it becomes relatively superficial and susceptible to trauma. which can result in formation of either a true aneurysm or a pseudoaneurysm with subsequent thrombosis. These patients will present with unilateral vascular insufficiency in the small ring or middle fingers. The ring finger is involved in about 50% of cases, the small and middle fingers in a third, and almost never in the thumb. That's a good way to rule this out. These patients will have symptoms including pain, cold intolerance, numbness, and weakness. On exam, they may have a pulsatile mass at the level of the wrist. They may have splinter hemorrhages, ischemic changes to the fingers, and digital ulceration. This is best diagnosed with angiography, in which you'll see the pathognomonic corkscrew sign on imaging. So treatment is usually guided by severity of symptoms. So usually start with non-operative options, including behavioral modification and smoking cessation. And then if that's unsuccessful, you can start medical management with vasodilators or antiplatelet agents. These patients do have acute thrombotic occlusion with ischemia. You can treat that with antiplatelet and thrombolytic therapy. So surgical options include resection or ligation of the aneurysmal segment and reconstruction with either a direct repair or an interpositional vein or artery graft. Arterial grafts are more physiologic and may have improved long-term outcomes. Pictures here show an angiogram in a patient with Hypothenar hammer syndrome and an ulnar artery aneurysm that was repaired with resection and direct repair. This is a suggested treatment algorithm for the management of Hypothenar hammer syndrome. So these patients have segmental occlusion with ischemia. You'll proceed with fibrinolysis. Typically, this is only indicated for acute onset digital ischemia. If an aneurysm with sufficient distal flow, you can just ligate it alone. Otherwise, you'll have to resect that area. You can repair that either directly or with an interpositional graft. And these patients have a thrombosed aneurysm. You can treat that with embolization and then resection as well. So Buerger disease or thromboangiitis obliterans is an inflammatory disease of the small and medium-sized arteries of the upper and lower extremities. It's most common in young male smokers. These patients will present with claudication and signs of limb ischemia, including rest pain and ischemic ulcerations. It's usually not seen in the upper extremities. Patients will have the characteristic corkscrew vessels on arteriogram. Because this typically has diffuse involvement of the small caliber vessels of the hand, bypass and revascularization procedures are usually not successful. The discontinuation of smoking is the only definitive treatment, and the prognosis is actually pretty good if patients quit smoking. If they have refractory pain, non-healing ulcers, or gangrene, then really your only option at that point is amputation. So atherosclerotic disease, chronic ischemia of the hand constitutes 4.8% of all patients undergoing vascular surgery. Likely the incidence of below elbow ischemia from chronic vascular disease is underreported. Comorbidities include diabetes, end-stage renal disease, and systemic atherosclerosis. Arterial occlusive disease has become more common as these comorbidities increase. And about 5% of patients with a chronic ischemia will have upper extremity involvement. So diagnosis, of course, history and physical with a complete vascular exam, and then arteriography for imaging, which is the imaging modality of choice. Treatment options include arterial bypass, which is the best choice for isolated occlusion and patent distal vessels. You also do arterialization of the venous system, which is more of an established procedure when there are no patent distal vessels. You'll strip the vein and anastomose to the artery to provide retrograde flow through the vein to the distal hands and fingers. And then lastly, angioplasty. You can perform a balloon angioplasty as distally as the volar arch. stenting is typically reserved for more proximal lesions, like in the subclavian, because of poor patency rates, with stenting of more distal occlusions. This was a paper published in PRS in 2016 out of Penn. It's a systemic review analyzing the outcomes of these different surgical therapies of sympathectomy, arterial bypass, and venous arterialization. This is a table from that paper. Showed that sympathectomy, arterial bypass, and venous arterialization resulted in pain relief in 89, 100, and 100% of patients, whereas successful wound healing occurred in 74, 93, and 75% of patients, respectively. Their conclusion was that when conservative measures fail to improve chronic hand ischemia, there are several surgical interventions available that are effective for last-line treatments. They included this algorithmic approach for the management of chronic ischemia of the hand. So, of course, you start with medical optimization. If they have continued symptoms, you'll get imaging. If there's no identified vascular lesion, you can perform a sympathectomy. If they do have a reconstructible segmental occlusion, you'll perform a bypass procedure. And if there's nothing that's reconstructible, you'll perform venous arterialization. So moving on to thoracic outlet syndrome. This is compression of the neurovascular structures at the superior aperture of the thorax. Affected structures include the brachial plexus in 95% of cases, subclavian vein in 4%, and the subclavian artery in 1%. Incidence is about 3 to 8 out of 1,000, and it's 3 times more common in women. Neurologic presentations are more common in females, whereas venous symptoms are more common in males, while arterial symptoms have no sexual predilection. These patients will present with an ache or dull pain and swelling in the affected arm. Most presentations are non-emergent and only require symptomatic treatment and referral. They'll have engorged veins on the hand and arm. And if they have arterial compression, they may have ischemic-like pain or claudication symptoms as well. So causes are typically anatomic. This area is surrounded by the anterior scalene anteriorly, the middle scalene posteriorly, and the first rib inferiorly. And these account for most neurologic cases. Cervical ribs are involved in most arterial cases. You can also have congenital fibromuscular bands as well. Patients who undergo traumatic injuries, such as motor vehicle accidents, can have a hyperextension injury with subsequent fibrosis and scarring that can lead to TOS. You can also see effort vein thrombosis, which is spontaneous axillary vein thrombosis after vigorous arm exertion. And then musicians are susceptible to this as well because they need to maintain their shoulder and abduction or extension for long periods. And lastly, neurovascular entrapment at the costoclavicular space between the first rib and head of the clavicle is another cause as well. So diagnosis, you want to perform a physical exam. You perform an elevated arm stress test in which the patient sits with the arms abducted 90 degrees and elbows flexed 90 degrees, and then you have them open and close their hands for 3 minutes. Patients with thoracic outlet syndrome cannot continue this and will develop symptoms. Most of the time, the exam findings in these patients are fairly normal, but they have venous systems. They may have edema, cyanosis, or descended veins. And if they have arterial symptoms, they may have pallor, coolness, pulselessness. They may also have lower blood pressure in the affected arm. For imaging, you want to get chest and cervical radiographs, which may demonstrate a skeletal abnormality. And then, of course, arteriogram if there's any evidence of arterial disease. So treatment, you want to remove any offending structures. This is most commonly the first rib, a cervical rib, middle third of the clavicle, or a fibrous band. You can also perform a thromboembolism or interposition graft for arterial obstruction. And if symptoms persist, you can perform a cervical dorsal sympathectomy. So, touch briefly on vascular anomalies. Start with hemangiomas. These can be infantile or congenital. Infantile are present after birth. There are 3 phases: a proliferation phase, a plateau phase, and involution phase. These are GLUT1 positive, which we've been tested on before. Congenital can be divided into rapidly involuting or non-involuting. Typically, rapidly involuting will involute by 6 to 10 months of age. Workup for these, you can get an MRI, which can help differentiate these from an arterial venous malformation. And then treatments, majority of these will spontaneously involute without treatment. Typically, treatment is resolved for symptomatic cases in which patients may have ulcerations, infections, bleeding, or for psychosocial factors. And this is best treated with excision or cryotherapy. So arteriovenous malformations. This is a result of congenital error and embryonic development between weeks 4 and 10, which results in abnormal communication, causing shunting from the arterial to the venous systems. These patients will present with a mass, pink stain, dilated veins, and skin ulceration. The shunting causes a steal phenomenon in which the blood flow is diverted from the high resistance capillary beds and can lead to ischemia in the hand. These patients will also have limb heaviness aggravated with dependency and relieved with elevation. Diagnosis: these patients may have a pulsatile mass or a palpable thrill. They may show Raynaud sign, which is a slowing of the heart rate during proximal compression. Imaging, ultrasound or a CTA. MRI has also become the new standard in preoperative evaluation, which can help differentiate high versus low flow arteriovenous malformations. Treatment: most of these can be managed medically. Surgical indications include hemorrhage, painful ischemia or non-healing ulcers, or congestive heart failure, which can be worsened by the shunting, as well as functional impairment of the hand. These are best treated with sclerotherapy, embolization, or excision, or a combination of the above. The images here show a patient who had a high flow AVM with pain and ulceration and had reconstruction of the ulnar artery with a reverse saphenous vein graft, as well as index finger amputation. And the pictures on the bottom show the 1-year follow-up in which they had no pain and good function with no signs of recurrence. Glomus tumors, I know we talked about this a few weeks ago. These are benign lesions containing cells from the glomus apparatus. So the glomus body lies in the reticular layer of the dermis and is responsible for thermoregulatory control. About 75% of these will be in the hand and 65% in the fingertip. These are commonly subungual due to the high concentration of glomus bodies in this region. They can be classified as solitary, multiple painful lesions, or multiple painless lesions. Symptoms include cold hypersensitivity, paroxysmal pain, and pinpoint tenderness. They may show love sign, which is intense pain with pressure over the suspected area, or Hildreth sign, which is pain abolished with a pressure cuff inflated proximally. These may also have a bluish discoloration. Oftentimes, you'll get an MRI to work these up, and these are best treated with excision. All right.